guys, if we can get everyone to go ahead and grab a seat, that way we can go ahead and get started. I know it's been a long day for everybody. All right, first I want to say thank you for being here. In case you don't know me, I'm Kathy at Stokes. I'm one of the organizers for Nurses Take DC. I want to say thank you for contributing and coming to this wonderful education session that you're going to get with Pam today. You get a 1.5 CE credit, and at the end, in order to receive that credit, we just need to make sure that you do fill out the evaluation form. When you hand us the evaluation form, you get the CE in your hand. You can fill out your name, your RN number, and then we don't report it to the state, so you'll have to do that yourself, okay? But make sure you keep it in your records and everything for that so that you get all the credit. So, this is Pam Robbins. Some of you may or may not know her. She was out like a butterfly today doing a great job at the networking event, so if you were here, you may have chatted with her. And you would realize how passionate she is about legislation and nurse involvement with legislation. So, I'm going to go ahead and let her tell you her history, since she knows it much more better than I. All right, and we'll go ahead and get this started. Hopefully we can get out at a decent time tonight, okay? Afterwards, we are going to have a sign-making party, so to say. That's why we have all the signs in the back. So feel free to linger afterwards if you want. Of course, if you're starving and you want to get out of here, I understand. It's all in how you feel, okay? All right, thanks.
Well, thank you, Kathy. I appreciate everyone's attention. It's been a long day. I think that your evaluation forms are in the back of your packet, so when we get done, go through those, or just put all 5 down now. And we'll be able to maybe about halfway through do a little stretch break, if that's okay, so we can continue to keep going. So I really appreciate the opportunity to do this wonderful session. I started out as a diploma nurse, graduated in 1930. And had to go on to get my master's because I wanted to teach really bad. Nurses are all teachers, so that's always a good thing. But to do that in the state of Illinois, you do have to have your master's. So for the last 5 years, I've taught health policy to nurse anesthetist students who first say, excuse me, what do I got to know about that? I said, you want to get paid? Our Nurse Practice Act says what your scope of practice is, and independent practice is something we've been trying to do for many years in Illinois. So about the 4th week, they start figuring out that they probably need to be a little more engaged in the political process. The one thing that, before I'm dead, is I want to have undergraduate schools teach political advocacy. I don't understand why that doesn't happen. So you can, in your own states, go back to your boards of nursing and start talking to the faculty. Usually there's an organization of deans and directors for undergraduate and graduate. They really need to infuse this because I do believe the employer would really prefer an uninformed, unmotivated nurse employee. And I've been fired for better jobs than that twice in my life. So, having a voice is one of those things that, this is an interesting part. So I was at Millikan teaching health policy, and we were having things with our Nurse Practice Act. And I started to circulate some of the information because I didn't quite appreciate the stuff that was being passed as a law. And she says, we're not going to be renewing your contract because, you're a little bit too political. Okay, well, you know what? It freed me up to be able to do all this wonderful stuff, show me your stethoscope and Nurses Take DC. So as God shuts the door, he hits you in the butt. He usually opens a window somewhere. So I do want to share with you, we've got some things that we have to say, which is the objectives, and we also have these CEs. The CEs are from Education Enterprises. So as an accredited provider for today's 1.5 continuing hours of education by the American Nurses Credentialing Center Commission on Accreditation, I have nothing to disclose to you, so that's this disclosure thing I have to tell you. And then we do have objectives today. Discussion on the similarity between patient advocacy and political advocacy. We also have the essential questions that a legislator is going to be asking you. There's a thing called citizen-centric, which was a survey of legislators as to what it is that they want their constituents to be able to answer questions on. So those are a couple of things that are like really important that you might run into when you talk to your legislators in the next few weeks, and maybe tomorrow if you have an appointment. And then, of course, they have two examples of how the nursing process and the political process are essentially mirrors. And the construct of your legislative dialogue to do your elevator speech. So I've peppered throughout this entire presentation research, documentation, there's scads of studies that have been done. And we also have the incredible opportunity that California nurses in that state had for almost 15 years had a ratio law that has had and been studied and has been a big secret because people like the hospital industry doesn't really want people to know about that. And to the point that there is another law that's out, a proposal that's out there by the American Nurses Association that is we can do it ourselves, we don't need any nurse input or help, which is the healthcare industry saying, we'll define nurse staffing, sit down and be quiet. We don't agree with that, and I think that that is where that idea about the grassroots process, about having people across the states, everybody knows that staffing can be really, really bad. I'm not going to say that there's places that staffing is really, really good, because some nurse managers and businesses of hospitals do get it, and they do see the advantages to that. So there's this vast dichotomy of whether it's a good place or a bad place to work. But on the general, I think that anywhere can be improved, and there's nothing that's going to hold somebody accountable unless there's a law that mandates it. So you can have a great chief nursing officer, and then she can get fired, and somebody else comes in, and you're dealing with the devil. So I think that we really have to think about and thank the American Nurse Association, which is showing us what we don't want, and then being able to show them from California what we do want, and then we have a couple of states that the New Jersey nurses are working on theirs, and also Massachusetts is working on a vote. Booyah! Massachusetts is working on the reform legislation. So under, over, around, or through is what I've always used as how we get to somewhere. The more pressure we can put on legislators to teach them, because they love nurses. I dated one in college. That's great, and we love that, but we really want to talk about this bill, the legislator. So in the beginning, I wonder if I can they like take this out? Oh my God, I'm free. Okay, so for the beginning.
You still stuck. Untangle it, you'll have more room.
Thank you, Nurse.
That was the right answer.
There's me undoing. So one of the things that we always forget about, that there were wonderful historians that have done health policy, tweaking their nursing process. And of course we all know Florence Nightingale. Florence Nightingale was the gal that was the mother of the hospital system, taking people and putting them in units, making sure they were clean and dry, and they had good food and dry dressings and stuff like that. Even though that she worked so hard, she couldn't vote. She was dead for 8 years before she could vote. And so she knew the people who did have the influence. So you have to know who to talk to. And that is, I think, the part that if you don't know the political process, whether you work in your hospital, in your cities, in your towns, on whatever place that policy is happening, state or federal level, you're going to be separated from the ability for someone who is elected to represent you. She used the people that were the soldiers and the generals because they were the ones that were in charge of the system. And so she got her statistics, which again we're working on today and haven't let that go. But I don't think the hospital industry really wants us to know all of the specifics of the good studies and research that shows that more nurses get better outcomes when they have lesser patients. And then we have our Lillian Wald, who was from New York. Anybody? Yeah. So Lillian Wald was an instructor, and one of her students came running to her one day and saying, "You've got to come and see my mom. She has had a baby and she's dying." So Lillian Wald went to her bedside, and this woman had had a child and was laying there for 3 days because she was hemorrhaging out. So she went and cleaned her and took care of her. the family kissed her hands as she walked out. She went back to her nursing colleagues and says, we have got to do something for the indigent in the slums. And that's where public health nursing came from. So again, thinking of problem, remedy,
Yeah.
enacted, and that's what nurses do over and over and over again. And then this lady down at the bottom is the first president of the Illinois State Nurse Association. I was a president of the Illinois State Nurse Association one time. I'm old, I did not know her personally. So Harry Fulmer is the gal that decided that nurses need to be educated, and that's where the licensure of nursing happened in the state of Illinois, because she believed that nursing and education were absolutely integral to moving the profession forward. So we have wonderful historians that have used the nursing process tweaked into the political advocacy to improve our lives. And then I'm in this picture with some of you too. Yay! Thank you, David Miller, for that beautiful picture. And so when you think about collective power, you're looking at it, and we're bigger than we were last year, and we're going to be bigger than next year, and we're going to continue to grow, because we're going to teach our colleagues and the public who pay for health care in the United States to understand that nurses' voices will help guide regulation, and they need to be educated, because again, nurses are kind of quiet and they don't really talk about things. So we're going to change that. So let's think about this little slide. And this came from the Institute of Medicine, and it was a Gallup poll of opinion leaders. These opinion leaders were the deans of colleges, business heads, all of these men that were talking about nurses and doctors. And they said doctors and nurses are absolutely the first and second choice to be entrusted. Kate, is that you back there? I love you. Okay, so there's New Jersey back there, the one woman wrecking ball. So you think about the things that nurses do as being trusted, but not so influential. And I read these slides over and over again, said that patients and nurses are not going to be the influencers over the next 5 to 10 years. And it made me very angry. And then it said that nurses need to have a little bit more of this envisioning, influencing and reducing medical errors, really not worried about primary care, but kind of focused on acute care setting. And probably the most insulting thing, that they really weren't perceived as being decision makers or revenue generators. Okay, so I really started to get angry after I started reading that. It's like, I know I'm valuable. You try to do this without me in recovery room and see how that goes for you. And then so when we think about how valuable we are, if we can't articulate it, that's where we seem to stop ourselves. And we've got to get over that barrier, because it said nurses really not having a single voice on national issues. And by the time I got down to the bottom one, I thought, oh, rats, that's kind of true. So we need to fix all these things, because unless we change the perception, that is somebody's reality. So nurses are supposed to be taken more of a leadership role, to have their voices heard and to have higher expectations. And so, oh my, let's kind of pull that back a little bit. I don't know if I can do that.
We have it.
Okay, that's right, you do. So all levels of nursing need strong leadership skills. And the idea that nurses are just doers and not strategic thinkers is something that we really need to focus on. Because maybe people think that's all we do is follow the doctor around and take his orders, after we decipher them, read them, correct them, and then put them into action. So the skills must be learned at various levels. And we already touched on the ability that nurses in undergraduate needs to be educated. Now, I'm not just talking about a one-shot, because I will go talk to the senior class for their leadership course, their coursework for that one semester. And it's more than a one-shot. There's no reason, and I really believe every state has an active legislative session every 1 or 2 years, that the students need to be engaged in whatever is the current policy issue that protects the public, or it's a nursing issue. Not everything is a nursing bill, but a lot of these things affect the policy and the public's health. So I think we should have some type of ongoing education in the schools of nursing, because these kids can vote when they're 18. So I don't understand why they wait until you're in your master's program to start even thinking about it. And then we have the frontline nurses, which are you guys. Those people that are out there doing the work every single day, 24/7. And how can we develop better delivery systems, which is what the Institute of Medicine told us. We know what's wrong. We always probably really need to know how to fix that in a remedy. And there's scads of research that shows, especially the critical care nurses comes to mind, about how you get a patient that is in the bed up and walking, and it increases their ability and shortens their length of stay because they've got them mobile. But you can't get somebody up when you don't have anybody to help you to do that.
Right.
So there's a lot of great ideas. You still have to have the manpower, woman power, to be able to make it done. And then you have your community nurses, when I think about Lillian Wald and the public health nurses that are always fighting for social justice issues. And then they are the social changes agents that are out there because they're speaking for those who cannot speak for themselves because they don't have enough money, or they aren't educated, or they're living in a very deplorable state that they can't seem to get out of. And then, of course, the chief nursing officers. Now, who doesn't like to beat up on somebody? But the reality is the chief nursing officers are handed a basket of money, and they're said, this is your budget. I don't care if they're 12-hour nurses, 8-hour nurses, 4-hour nurses. I don't care. Here's your money. Figure it out. So as all of these components as to how we are represented in different places, the chief nursing officer isn't going to be sitting at the table of the board of the hospital. There's less than probably 3 to 5% of chief nursing officers that are part of the discussion of how the hospital works. There's less than 20% of physicians now. The rest of them are businessmen and women. And so the business model of healthcare has evolved. As I've been a nurse for almost 40 years, there's a disconnect because our hospital in Joliet, Illinois, the business people and the doctors of our community were on the board. Now the board comes from a different place altogether. They're not even people that are in our community. So that when they keep separating, I think you lose your ability to have your autonomy, and that board isn't, I don't think, concerned with anything except the bottom line, which is exactly not what we base our professional standards off of, which is professional nursing standards. And then there's business standards, and those two sometimes don't even intersect. So if we don't expect to do anything to change, we really can't expect any change. And that's where I was so excited about coming to show me your stethoscope and the Nurses Take DC. So how is it? Can you imagine if nurses were valued to the commiserate level of what it is that their need and their value is, that a journalist would have an entire Rolodex, now there's an old word, a Rolodex of nurses from all different areas to be able to just pick out this nurse. I want to talk about an oncology nurse. I want to talk to the nurses that do the cardiac catheterizations. That they would have this entire resource. What if that we just didn't think about medical research, that we thought about nursing research being on the cutting edge and leading and driving the healthcare delivery system? Or that the nurses would educate patients, their families, and friends, and being cognizant that if you don't have the right numbers of nurses or the right skilled nurse, that you might not make it. I'm recovery room. I don't know nothing about birthing no babies. You know, people start screaming in pain, I'm giving morphine, because that's what I do in my recovery room. So it's important that they understand the value of nursing, but we have to be able to communicate that. And then if patients that are facing medical treatments would inquire on nurses' qualifications, not just as, do you know a good doctor in town? Well, where are the good nurses? And where are the places that the nurses have adequate staffing that I don't have to worry about spending the whole entire night with my mom or my dad in the hospital because I'm afraid they're going to fall. I'm going to just touch that there. Whoops. Let's go back. So one of the things that we have to do is we have to remedy. We have to remedy by step one that only nurses can inform other people about nursing. Because I never really got candy in the recovery room. Nobody remembered being in the recovery room because Versed and anesthesia are really good agents. So the thing is how do you explain to somebody what they do? What do you do to make sure that they understand that you are part of their recovery? The second step is that nurses have to make a public communication and education about nursing as a part of their work every single day. Say you're a nurse and a patient comes to you in the operating room and they say, hello, my name is Pamela Robbins. I'm going to be your registered nurse here for today. I'm going to be the nurse that's going to be in your room taking care of your needs while you're asleep. I'm going to help coordinate not one, not two, but three particular people, because this is a theater and there is a show about to happen and you're going to be the star. So these are the things that you really help people understand. It takes how many nurses? I would always laugh. It takes 4 people to have an operation, and they bring them to me in the recovery room with all their IVs and their dressings and their charts all in there, and then they all leave and I'm by myself. I was a 23-year-old baby nurse in the recovery room, and I had at one time 3 patients in the room at one time. Okay, how crazy is that? It's like, you know what, I said, you know, there's something wrong with this ratio. So, and so the last one is we must overcome the internal obstacles that keep our glass ceiling above our heads. And I'm going to show a couple of slides on that. So if we could commit to these 3 steps, nurse visibility would improve and our profession would be absolutely regarded as something cutting edge and valuable. So nurses have the means, the motivation, and the opportunity to make it happen. So what does that motivation, means, and opportunity really mean? Well, we can talk to, and how many of you were in the back room today talking to social media? Yes, we have to tell people what it is and why we're here. We can do op-eds in our local papers. We can talk up about this bill. We can help educate the people that are in our circles that there is an important part, because the people that are around us love us, they do. But the people that don't understand what we do need to understand how we do that, and then we need to go farther out and explain that to other people that are the public and the legislators who aren't nurses, and we talk to lay people all the time. So I think that teaching part is something that we already have that skill. Motivation. Here's something. Instead of complaining, and if I hear one more time that nurses eat their young, we have to stop ourselves. We are frustrated. When we get frustrated, we do not want to be in a good mood, and we're going to pick out anything that isn't right. We need to start switching our brains around to understand that the environment isn't under our control, and that the people are trying as hard as we are, and that we need to praise people when somebody does something good. That takes you to change. And these young nurses that come out, and after 3 or 4 years they go out and do something else, they said, I was not educated in this manner. I cannot do what they told me I had to do, and I'm not going to stay in this environment. And they go on, they get a couple more years, they lateral and get another degree, and off they go. And out, not just for a year, we lose a nurse for an entire career. And that's the part of stuff that makes me cry, because we have the power in our numbers to change that equation. I think the innovators and the things that we have done in nursing, I think about the things that nursing over the last 50 years, and I hate to say this, but geez, I've been around for 40 of those, the innovations in pain control, in innovations in hospice, in intensive care, in education, advanced practice nursing, the research. I think of all these things that we do, that we have emergency room nurses bring families in when you're coding a patient in the most crucial time of their lives. This patient is going down and the family's outside. And you bring them in so they can see and witness how hard you're working, and also how hard their family was trying to help themselves. And when it doesn't go the way that everybody thinks, that they were there. You're going to make me cry, because nurses care, and they want the family to be okay, because this is the worst few minutes of their lives, is they see that soul go. And their nurses said, we got to get families in here. So I think that we have to praise what we do, support ourselves, and continue to teach people what we do, because the mom that has the baby that doesn't survive, and that togetherness that they give, that quiet time, so they can take pictures of that baby, because that baby's going to leave them, something that they've worked on for 9 months. So that's the love and caring of spirituality of nursing that needs to be continued, because nursing is not just get them in, get them out, get them in, get them out. That's not how we do it. And people don't understand how much we cry inside when we can't do what we were even taught to do, or the outcome isn't the best. So there's this gal, Sheryl Sandberg, and she writes a book that says Lean In. I don't know if you've read it. It is about women in business. It also talks a little bit about how women have barriers that they create themselves and trap themselves in because it's safe. It's easier to be safe sometimes than it is to lean in or to not raise your hand. You know what could be a better idea, but you don't put your arm up. You need to sit at the table, sometimes literally sit at the table. I've seen nurses sit around the perimeter of a room in a meeting. Not up at the table, but out in the perimeter. It's safer. There's a little barrier there. Okay, present company are not in that group. You're here because you want to make a difference. You raised your hand to come here, spend your cash, to go talk to people that are not too far from here, but live probably just as close to you at home. Because you have seen the power of the collective. And that's the part that you are not of those people that are sitting around the perimeter of the room. You're up here at the table. Keep grabbing people to join you at that table, because we together can raise our expectations of what it is that we want to accomplish. And failure to demand what we need, she talked about, she was one of, I think it was, I don't know if it was Facebook, it might have been the place she was at before Facebook. She was like 18 months pregnant, running to get to the office, no pregnancy parking, no women's bathroom. She's like, are you serious? So she had to negotiate those things because they weren't there, because she was in a man's world. So when I think about women in nursing, who are primarily, the majority of us are women, we can find ourselves trapped in some of these things. So we need to believe in ourselves. You guys do. We need to sit at the table. You are. We need to negotiate effectively. We as nurses know how to negotiate. When you stick an NG tube down somebody's throat, or stick 3 inches of stainless steel in their buttock, anywhere else that would be assault and battery, okay?